So, a lovely but belated welcome to this session. This is concurrent session 9 on the long term, and we've already sorted out where everyone's meant to be. Thank you for joining us this afternoon. Our first speaker is Amelia Hicks, and she'll be coming to us via Zoom. So, thanks very much.
Thank you. So yes, my name is Amelia Hicks, and I'll be presenting today some of our work looking at factors facilitating recovery. So some positive, good news for your afternoon in Sydney. And this work was a collaboration between the Restore team and the team at Monash Epworth Rehabilitation Research Centre. And the write-up of this work was led by my colleague, Dr. Marina Downing. So, as we all know, recovery from severe traumatic brain injury is a long-term and often lifelong process for many individuals. And so it's really important that we try to understand some key factors that might actually help with recovery so that we can support people to have the best possible outcome. And as many of you would be aware, a lot of research doesn't focus on the positive, but rather looks at the negative. What are the factors that might hinder or be a barrier to recovery? So there is a bit of quantitative data, a bit of survey data, where they have identified some variables that do facilitate recovery. So for example, pre-injury factors like having a higher education, time of injury also seems to be positive, being younger at time of injury, also having a less severe injury. In the post-injury period, having a good therapeutic relationship with your rehab doctor and clinicians, as well as rehab support and family involvement in care. There's also some great research out there looking at the positive benefits of resilience and adaptive coping. So this is all wonderful. It's a good foundation, a good place to start. But what we really need to understand is a more richer understanding of what are these positive factors. And the best way that we can do this is to have qualitative interviews with people with living experience of traumatic brain injury to find out from their very important perspectives what they think is helpful in their recovery journey. So that's exactly what we set out to do. We wanted to look at positive factors for recovery after severe traumatic brain injury. And we interviewed both individuals with TBI and their close others at approximately 3 years after injury. So moving into that more long-term, certainly post-acute period. So we had a total of 16 participants. So 9 of these were individuals who'd sustained a TBI, and we had 14 close others. There's a little error on the slide there. And there was 72% males with TBI, and the mean age at injury was 40 years old. So they were a bit of an older sample when they sustained their injury. And mostly they'd sustained their injuries from road traffic accidents. So the study was a mixed methods design. So we did capture some quantitative survey data, but the main focus on what I'll be presenting today is our qualitative research. So as I mentioned, everybody was around that 3 years post-injury mark, and we did semi-structured interviews. So I'm sure there's a lot of qualitative research being presented at the conference, so you'll no doubt be familiar with this term now, but for those of you who aren't, it refers to an interview style where we certainly go in with some questions and some ideas that we would like to explore, but we certainly really encourage participants to take the conversation where they want and to talk to us about the things that they think are important. So we hope and encourage them to lead the way. And then we did a thematic analysis based on the principles of Brown and Clark. So just going through the transcripts, using the data within the transcripts to identify patterns, ideas, themes that were coming up and that were coming up across a number of transcripts. And we then summarize those into some key themes and sub-themes to make them digestible for the reader and to tell a really nice story about recovery at 3 years post-injury and what's helping. So what did we find? Well, we summarized our 3 main themes into having a support network, being positive and engaged, and getting good care. So let's go through each of those. So first of all, not surprisingly, having that really good critical support network. So this included both social supports but also, of course, funded and non-funded assistance. So individuals with TBI reported that their social support network of family and friends was really positive for their recovery, not surprising. So one of our participants said, my mates as well, they've been absolutely fantastic for me. I think it's just the closeness of people you know and what they're willing to do for you, and that just helps you along the way. Positive factors identified under assistance included having a good experience with insurers, which, as we all know, is not always the case, unfortunately, and having financial assistance as well, which is absolutely critical with the cost of care. So one of our participants reflected the compensation body has been very good right from the beginning, which was really great to hear. So they reflected that they compensated this person's loved ones for loss of his earnings, and when we ring them, they respond. It's been a really good relationship. The next one, being positive and engaged. So this included being able to participate meaningfully in life, being positive, using compensatory strategies to help get back into valued activities, and also being fit, healthy, and happy. So with respect to participation, there were several positive factors identified that really helped people within their recovery. So returning to driving was really important for people, returning to work or study, and returning to home duties, just fulfilling those really important roles in your life. And also returning to managing your own finances, so feeling that sense of independence and autonomy. So one participant explained, when I was doing my return to work, just being out of the house and being or thinking or trying to be an active part of the community just made a big difference. Another key theme that I'll pick out here is being positive. So having a future focused and hopeful mindset. And that was perceived as really, really critical by a really great number of our participants. So somebody reflected, one of our participants reflected, you can either just sit and feel sorry for yourself, or you can get up and try to live life as best you can and make the most of it. So our final theme was getting good care. So this included two main categories. Firstly, experience in the acute hospital or the inpatient rehab setting, and secondarily in the outpatient rehab setting. So a number of really positive factors were identified in the acute hospital or inpatient setting. So one was good communication between staff and family. So one close other reflected, we were kept informed, and as a family, you are in shock. You don't want to be confronted with every single little thing all at once. It had to be given to us piecemeal in a sensitive manner, and it was done well. In the outpatient setting, participants identified the importance of discharge planning, and continuity of care was a major theme that came up quite a lot in our interviews. So one person reflected, once we found a doctor who could help, that for me was just a godsend, because all of a sudden it put a whole lot of the behaviors into context, and it really just helped to move things along. So just again to go over these main themes and what we really took from this research. So firstly, having a support network. So families, friends, carers, absolutely essential. And people felt that it positively impacted their psychological functioning, their fundamental satisfaction with life, quality of life, and also helped them to redefine themselves after their injury. Being positive and engaged, so being hopeful and being determined to recover. And a number of participants reflected on this idea of choosing to live as a survivor rather than a victim. There were a number of people as well who also reflected they felt actually the injury had been a catalyst that motivated them to become what they perceived as a better person. And finally, getting good care. So what's really critical is ongoing access to comprehensive and good quality care across the acute and into the outpatient, and obviously beyond as well. And a lot of people spoke about multidisciplinary therapy and how important that was. But we had a few people as well really emphasizing how alternative medicine had worked for them. So things like Chinese medicine. And finally, having as much information as possible conveyed throughout the recovery process, but in a piecemeal and sensitive way, was really important. So overall, what we can take from this study is the importance of enhancing those factors that I've just run through um, in service provision and rehabilitation as much as we can, with our hope that by doing so, we can potentially enhance the quality of life, well-being and overall outcomes as severe TBI survivors move into that more chronic long-term phase of recovery. So with that, I will acknowledge all the participants who shared their stories with us. We're so grateful to everybody, the co-authors on this work, especially Dr. Marina Downing, who, as I mentioned, led this paper, the Merck and Restore team and funding support. I'm very happy to answer questions if it's something that you can facilitate there in Sydney, if there's someone who can put a microphone around. Otherwise, you're very welcome, of course, to contact me at my email or over Twitter. Thank you.
Jenny Ponsford couldn't make it here today to be with us, so she has recorded her lecture. She's currently in Europe, taking the opportunity to head there to do her work after 2 years of being locked out. So we have Jenny's presentation next. I think there's some bad news, is there? No, we're all right, okay.
I'd like to start out by acknowledging my co-authors, Aviva Lefkowitz, Amelia Hicks and Marina Downing. It's well known that traumatic brain injury results in significant physical, cognitive and behavioural sequelae that impact many aspects of the individual's life. Most of the research that's documented these changes has been conducted in the early years after injury, and there's been limited study of the longer term journey over many years from the perspective of the individual who has sustained the injury. So the aim of this study was to investigate from a qualitative perspective the experience of traumatic brain injury over many years after injury, with individuals reflecting from acute recovery right through to living long term with the injury. We included 28 individuals with moderate to severe traumatic brain injury recruited from Epworth Healthcare as part of the longitudinal head injury outcome study and followed up over many years. They included 11 females and 17 males aged between 35 and 86 and ranging from 11 to 31 years post-injury. The qualitative study involved the conduct of semi-structured face-to-face interviews that focused on three main areas. First, individuals were asked to comment on the impact of the injury on specific life domains, their experience of rehabilitation and long-term support, and their personal journey over time. We undertook a 6-phase thematic analysis of the transcripts as prescribed by Braun and Clark, identifying common codes and then organising the codes into themes and developing a thematic map. So this is the thematic map that we developed, which reflects the experience of living long-term with traumatic brain injury. Time is represented horizontally. The map demonstrates that traumatic brain injury causes physical, cognitive, and behavioural impairments and changes in mood. And these in turn impact the domains of work and study, relationships, social life, and hobbies. The arrows indicate the ongoing nature of these impacts, and the shading in them indicates that the differential progression over time, with solid shading indicating persistence of the problem, while gradient shading shows that there was some resolution. Now, each of these impairments is targeted with rehabilitation, represented by grey at the back, and this is most intensive in the early period after injury, but for some it continues over many years. And finally, the map lists the factors that have helped recovery, such as support or having a positive attitude. And then at the bottom, we see the factors that have hindered recovery, such as a lack of information or insurance problems. Overall, each of these factors collectively combine to influence the individual's current status many years post-injury. Now, of the physical changes reported, the most common included problems with balance, headaches, pain, sensory changes affecting smell or taste, and fatigue was also reported, especially in the early stages, but continued for some. Most participants reported persisting cognitive impairments in the domains of memory, concentration, speed of thinking, executive functions such as planning and judgment, and difficulties with comprehension and word finding. As one said, compared to a computer, my hard disk was all right, but my RAM had been cut down to about half the size and was like first in, first out. Many participants struggled with low self-confidence early after the injury as they confronted their loss of capacity to engage in so many pre-injury activities. For some, this did improve over time, but for others, the lack of self-confidence persisted. Anxiety and depression were also commonly experienced, especially early after injury, as individuals worried about the impact of their injuries on their future. But interestingly, depression had gradually dissipated over the years after injury for the most participants. Some participants reported becoming upset more easily or experiencing emotions to a more heightened degree. Irritability was also a common problem that had continued for some. Now, there were many life domains that were impacted by the injury. For students who were studying prior to injury, continuing their education proved to be difficult. Some commenced different courses with modifications, such as part-time workload or return to study assistance. For many, employment-related difficulties were particularly distressing and significantly shaped the interpretation of the TBI experience. Being made redundant on medical grounds, to me, is the biggest soul-destroying issue of the accident, said one. A few participants were never able to return to work, while others returned to work in a temporarily altered capacity or changed positions permanently. Some reported poor treatment by their employer, whilst others said that having a supportive employer had been the key to their staying in work. Many participants reported changes to their social life, especially in the early stages after injury, particularly the loss of friends. Now, whilst these issues resolved over time for some, others reported continuing social issues, including difficulty making and maintaining friendships. The injury often negatively impacted new romantic relationships due to ineffective communication, argumentativeness, anger, and a sense of changed identity. In commenting on rehabilitation, most participants expressed satisfaction with their inpatient rehabilitation experience. It's important to note that these people were all covered by TAC or work cover and had received rehabilitation. They felt the services and therapies were helpful for their recovery, and the staff providing them were professional, warm, and caring. For many, this continued in the outpatient rehabilitation phase. But for a few participants, their positive experience was somewhat tarnished by discovering, say, a physical injury that had been missed and that required ongoing treatment. Some participants reported ongoing therapy being offered as needed, but others felt abandoned. The rehabilitation hospital threw me out after a year onto the cold streets of despair, said one. Some had ongoing battles with insurers to get support for necessary physical or psychological therapy, whilst others were appreciative of the ongoing support and treatment they received. Participants mentioned various factors that helped their social and psychological adjustment throughout their post-injury journey. During early rehabilitation and beyond, support from friends, family and loved ones was seen to be absolutely vital. Resuming previous hobbies helped participants feel that they'd returned to their pre-injury selves. Physical hobbies such as yoga and Tai Chi proved to be therapeutic. Participants also noted that they developed memory aids or developed strategies to cope with their memory difficulties. Others found that just gradually getting back to community activities was most helpful. For many, they found that there was that time what acted as a therapeutic remedy. Now, regarding their views of their recovery, participants had variable views. Some felt they'd made a full recovery. Some felt that they had lingering consequences and others felt they would never recover, with approximately even proportions in each category. The participants reported varied trajectories of recovery. Just under half stated their journey had become progressively easier over time. Others reported complete or partial recovery early after the injury, but little further change over time. And a few participants described a less linear, more fluctuating pattern of recovery. Many participants reported having a negative attitude towards their injury, especially early in recovery, describing a sense of victimhood and helplessness after an injury that had happened to them that was outside their control. The invisible nature of their injury and resulting judgment from others was key to their negative conceptualization. However, many participants grew to accept their injury as time progressed. Over 3/4 of participants mentioned at least one positive outcome, most commonly some form of personal growth, such as increased empathy. I have a better understanding of people who've been through severe injuries, and I'm more sympathetic or would allow them more than perhaps I would have if I'd not been through something similar. For others, a sense of self-acceptance and open-mindedness was fostered from feeling fortunate to be alive. I wouldn't change the experience for the world because I'm a better person today. I'm much more in touch with myself and my feelings. So to summarise, it's clear that traumatic brain injury survivors experience chronic sequelae that affect many areas of their lives and require long-term therapy and adaptations. For some of these individuals, the rehabilitation and insurance system that supported them early after injury had not provided the much needed ongoing therapy, highlighting some gaps in the system. But others expressed appreciation of long-term supports. The value of informal supports such as family and friends, the nature of which often changed over the years, was also highlighted. But this study suggests that at least a proportion of survivors of traumatic brain injury can overcome these problems over time and put the impacts of the injuries behind them. After their initial experiences of anxiety and depression, a remarkable feature of almost every interview was the experience of personal growth through the experience of injury and recovery. The ability to take something positive from the experience that led to a sense of inner strength in the face of adversity. Now, this study certainly does have limitations. We were reliant on somewhat deficient memories to remember back over the years. Those who agreed to be interviewed may represent a somewhat biased sample. And of course, all of these individuals had received rehabilitation support. Nevertheless, these qualitative experiences do offer a new and importantly long-term perspective on the experience of individuals with traumatic brain injury, who many of us only see in the acute stages of recovery. It's helpful for us and for them to know what lies ahead. And above all, it helps us to take a long-term view in planning rehabilitation support services to maximise long-term quality of life. Thank you very much indeed.
Next, we have Stephanie Bird's presentation. Oh gosh, I get all the tough jobs.
For having me. I apologise I can't be there in person. I really wanted to be, but I'm stuck in Melbourne at the moment. But I appreciate you listening to my recording. I'm the study coordinator of the Women's Healthy Ageing Project, which is a collaboration between the University of Melbourne and Royal Melbourne Hospital. Today I'm going to be presenting our work on head trauma, a sign of early cognitive ageing decades after community brain injury. So we know that TBI is a leading cause of death and disability worldwide, and that it affects approximately 54 to 60 million people each year, but that's that we know of. So it's now widely accepted that it's an ongoing neuronal injury rather than an acute event, and that it's associated with the onset of other neurodegenerative disorders, but we're still not clear on just how much damage it actually triggers. We also know that impairments occur in behaviour and cognition across multiple cognitive domains, which can be short-term or long-lasting, and of these, executive function and episodic memory are commonly reported. However, current literature does not necessarily reflect true figures of how many people in the community have actually suffered a TBI, because it generally focuses on clinically diagnosed TBI and missing the critically non-clinically reported injuries. There is also limited data that follows up patients longer than 12 to 24 months post-injury, and also on the impact of early life TBI on cognitive aging processes. So here we aim to examine the longitudinal cognitive changes that occur over a 12-year period in a cohort of healthy aging women and determine whether a relationship exists with community self-reported TBI. We hypothesize that such a relationship does exist, whereby women who reported a history of TBI would perform worse on several cognitive assessments compared to those without. Data used in this study was taken from the Women's Healthy Ageing Project, which is an ongoing longitudinal study of 438 Australian community dwelling women who were aged 45 to 55 years at baseline in 1990. It was initiated to examine women's health from midlife, so before the menopausal transition, and into aging. It collects an extensive range of measures, which place it in a unique position to consider the life course temporal changes in risk and the development of diseases of aging. History of head injury was self-reported with the question, do you have a prior history of serious head injury? And additional details were collected, including a description of the injury and the year it was sustained. Verbal fluency and trail-making B tests were used to assess executive function, and verbal episodic memory was assessed using the word recall subtest of the California Verbal Learning Test 2nd edition, or CVLT, and the consortium to establish a registry for Alzheimer's disease, or the CERD. In total, there was complete neuropsych data for 110 women across 3 follow-ups over 12 years, 9 of whom reported previous history of head trauma greater than 15 years prior to the 2002 baseline. Due to the small TBI sample size, 5 independent control groups comprising 18 samples were drawn from the larger control sample using random sampling with replacement and controlling for age, education, and ApoE gene. We used Mann-Whitney U-test to compare median composite scores for the TBI group and controls for both executive function and verbal episodic memory, and then examine the results across the 5 data sets. So in 2002, median scores for executive function were similar for both the TBI group and healthy controls. In 2012, scores appeared lower in the TBI group, and this difference was greater in 2014, although these differences did not reach significance. A similar pattern was observed for verbal episodic memory, where an increasing rate of decline was seen in the TBI group compared with the healthy controls, although again none reached significance. These results do suggest that TBI may accelerate normal cognitive aging processes, so we decided to investigate further by looking at the severity of injury and time since injury in our individual samples. Interestingly, we found that scores for both executive function and verbal episodic memory were better as injury severity increased, which could be reflective of the level of care at the time of injury. So this one's verbal episodic memory. So for example, a woman who ended up spending time in hospital with a severe TBI could have received more comprehensive care than the woman who fell off a bike and resulting in a more extensive recovery. When examining time since injury, we saw better mean scores for both executive function and verbal episodic memory as time from injury increased. This provides evidence that recovery continues well after the injury is sustained. So in summary, we first found that executive function appeared to decline at a faster rate in the TBI group, and that verbal episodic memory performance was worse on average across all years in the TBI group, but with a much wider spread of scores. This could suggest early aging processes may be triggered by TBI. Next, we found that executive function and verbal episodic memory scores increased as injury severity increased, which could be due to the level of care provided at the time of trauma. And finally, we found that executive function and verbal episodic memory improve with time since injury, providing evidence that recovery continues long after the injury occurs. Now, it's really interesting that despite this sample not being large enough to reach statistical power, these patterns were consistent across all of the 5 datasets. So other limitations to note include head injury was determined by self-report. So some women may have forgotten to report a previous injury, which would actually be consistent with research indicating that memory may also be affected following TBI. This also means that the details regarding the injury were not always as comprehensive as clinical studies. For example, it's not clear what areas of the brain were affected, and severity is dependent upon the participant's discretion, not the clinician's. Finally, only moderate to severe head injury was reported, as the question was serious head injury. So data for mild to moderate TBI or repetitive mild impact were not captured in this sample. As such, the Women's Healthy Aging Project will continue to explore the relationships observed in this small study as we continue to follow up these women until death. Future studies will also examine these cognitive trajectories in a nationwide sample that will include a broader range of TBI severity. So the main message I want you to take away from this presentation today is that the prevalence of TBI is likely to be much higher than reports indicate. And despite the most obvious limitation of the small sample size and lack of statistical power in this study, these findings warrant future research to investigate them further in larger populations. Now, given that this study is a 30-year study, there's a lot of people to thank for putting it together. And I would like to thank you for your time. And if anybody has any questions, I am available via email. Like I said, apologize I can't be there in person, and I hope the rest of the conference goes really well.
I'm getting really used to pressing the arrow on the keyboard, and I'm going to be doing it again. We have another presentation from Amelia Hicks. Yes. So we'll make that available. The question was, will we share the email address? I believe all of the slides and any materials from the conference will be available to registered delegates after the conference as well.
Okay, hello all, me again, twice in one session, so lucky. So shifting gears though quite a bit and moving quite further down the track post-injury. So this was our work looking at cognitive decline decades after a traumatic brain injury in our prospective controlled study. So again, this work was done at the Monash Epworth Rehabilitation Research Centre in Melbourne. So as we all know, impairments in cognitive functioning are really common following moderate to severe traumatic brain injury in areas like processing speed, attention, executive function, memory. And for many individuals, and what I'm really interested in, is that this cognitive dysfunction is a chronic problem. But one thing that we really don't have good data on is the cognitive deficit persistent but actually stable over time, or is there some ongoing change? So there is a little bit of longitudinal research out there that can answer these questions, so research that has more than one time point, but mostly this is in that really early period, so 1 to 2 years post-injury, where we find mostly that there are improvements in cognitive functioning. But outcomes become more varied as you move beyond 2 years and up to 5 years post-injury. So we start seeing some interesting divergent trajectories. So some people indeed stabilizing, some people continuing to improve, but it does appear that there are some people who are perhaps declining. What about in that long-term period that I'm interested in? There is a bit of research there, but in terms of the methodologically rigorous, good quality stuff, there's really only 2 studies that have been done to date. So these both looked at cognitive change over a 30-year period, so it's really great data, up to 40 years post-injury. And both of these papers were consistent in concluding that there was indeed a worsening of cognition over time. But along with understanding these trajectories, what we also need to, or what we're also interested in looking at, is what are the factors that might impact whether somebody does indeed remain stable, improve, or decline over time. Little is known about these factors that might have an influence in that long-term chronic 10 years or more period. But 4 factors that have been examined to date in the earlier period include how old you were when you had your injury, how long it's been since you had your injury, how severe the injury was, and also your cognitive reserve. So your cognitive reserve refers to your brain's ability to compensate and cope with injury, such that the amount of insult or injury won't be as clinically observable if you have a high cognitive reserve, and if you have a low cognitive reserve, it'll take less injury and insult to have those impacts on cognition and function. I always find that very hard to explain, so I hope I did an okay job. So what we did in this particular study was we looked at the trajectory, so the change over time of neuropsych performance, which is just a fancy way of saying cognitive performance, in individuals many years after a single moderate to severe TBI, and we compared it with some controls. And we also had a look at these factors, right? So we had a look at whether change in cognition was associated with age at injury, time since injury, PTA duration, which is what we commonly use as a marker of injury severity, and IQ, which we use as an indicator of cognitive reserve. So this was a prospective longitudinal study. So we did have an initial time point between 2002 and 2007, where a previous PhD student who worked with Jenny Ponsford was able to do an amazing job at recruitment and recruited 120 individuals with traumatic brain injury and 134 controls. Unfortunately, fast forward to 2018, 2019, when I was doing my PhD, we did have a little bit of trouble finding people with the people using a lot more mobile phones, I think, is possibly part of it. So a lot of disconnected landlines. And of course, unfortunately, a number of people had passed away. So we ended up with 53 individuals with traumatic brain injury and 26 healthy controls for our study. So the characterizing our sample for you, we had predominantly males in our TBI group who were around 60 years of age with 12 and a half years of education. We did a really comprehensive neuropsych battery, but we decided just to select a few key measures. And we chose this because previous research conducted at Merck has shown that these tests are particularly sensitive to differentiating between cognitive performance of individuals with TBI and controls, and are really sensitive in that chronic period as well. So for memory, we used Ravel, and for any neuropsychs in the audience, we use trials 1 to 5. Processing speed was the digit symbol coding test, and trail making test B, total time for executive functioning. So what did we find? So I will go through this fancy looking figure, but the key findings are that our individuals with brain injury did perform worse at both time points, at initial and follow-up on all cognitive tests. We found that both groups, our TBI group and our control group, were both declining over time on all cognitive tests. But the key finding, the thing that we set out to examine, and what we found was that the TBI group did not show greater decline over time. Now, the best way to really highlight this for you is if you have a look at panel B in this figure. So this is RAVEL, this is our memory measure. You can see our TBI group in red, control group in blue. Thick lines represent average score, with the shaded lines representing individual scores. And you can see, yes, the TBI group is performing worse initial and follow-up, and both groups are moving slightly down, but moving almost beautifully in parallel, showing that there's no greater decline in the TBI group, which was wonderful to see. So in terms of those factors, we didn't find any association between those factors with processing speed and memory. So that was the age at injury, time since injury, injury severity, and IQ. One significant finding was that executive functioning performance was associated with age at injury. I know it's late in the afternoon there for you, but if you can follow this, being older at injury had a greater adverse or negative impact on executive functioning at the second time point. So if you were older when you had your injury, it had a negative impact at that second time point, when you were further post-injury and when you were older, right? So what to take from all of this? Well, really, if you remember one thing from this presentation, it's that individuals in the chronic post-injury period did not show any greater cognitive decline over an average of about 12.5 years compared to controls. And what we think we're seeing with respect to those declines in performance is just healthy aging. So you might be sitting there thinking, well, this doesn't really align with the previous two studies that I mentioned, and you are absolutely correct. So some reasons, that we've come up with that might account for these differences is the samples are quite different. So the samples used in the two previous studies both had 95% penetrating head injury, which may have had some impact on their results. They both used military populations. And what we know about military samples with TBIs, they have higher comorbid PTSD, polytrauma, chronic pain, and substance abuse. So it's very possible these factors acted synergistically and had an effect on cognition. And finally, in the military samples, they're not restricted to one single TBI. So all our work is very strictly restricted to one moderate to severe brain injury. And given there's a bit of research coming through that having multiple head injuries might have a dose response effect with outcome, it's possible that that also contributed to their findings of ongoing cognitive decline. So how to interpret some of those findings around the factors? So as I said, individuals who are older at injury may experience greater difficulties with executive functioning as they age. We didn't find any significant associations for IQ or injury severity. And interestingly, that's actually consistent with previous research. So both at 1 to 5 years and in the longer term, there hasn't been associations found between injury severity and change in cognition over time. This is really promising, right? Because injury severity, unfortunately, cannot be changed or rehabilitated. And finally, no associations with time since injury. So what this suggests to me is that it's increasing age and not the increasing number of years that one lives with a TBI that's more important for cognitive outcomes. So, of course, the biggest limitation is the small sample size, and the sample size was uneven as well. And always possible there was bias in the sample. So what we did to try and interrogate that a little bit was we compared the group of people who took part in my PhD and the follow-up compared to those who took part in the earlier research but then could not be contacted for follow-up. And we did indeed find that in both our TBI and control group that those who enrolled had more years of education and a higher IQ. But given we found that same trend in our TBI control group, we would like to suggest that that means there's not problematic bias with respect to those variables in our sample. So this work was published about a year ago now, I think, April 2021. So if you would like to have a read, it is in Neuropsych Rehab. Just to finish off, I'd like to thank the Merck team, my PhD supervisors, Jenny Ponsford and Gershon Spitz. I always like to really give a heartfelt thanks to all the participants who took part in my PhD research. This is just one aspect of the whole protocol they took part in, including multiple brain scans, blood tests, just a group of absolute legends who I am indebted to, and funding support from the NHMRC. As I said, any questions, please do reach out to me via my email or Twitter. I am very happy to answer questions now, but I think maybe that's not going to work from a tech perspective. I hope you enjoy the rest of your conference.
Thanks, Amelia. It was lovely to see you on the big screen. So, I'm not sure if she can hear us. But Amelia's details are available if anyone has questions for her and needs to contact her. So just come and see me if you'd like those details. And I think she had them on the screen during her presentations as well. That concludes today's work. You've all worked very hard. In about 15 minutes, the Michael Hutchence movie is going to be held in this auditorium, and I encourage you all to stay. Grab a drink and have a stretch and come back in. But